Yeah, thank you. So yeah, I understand you've had doctors come here before. I'm probably the first cardiologist who's come here before to your meeting. So I like that kind of introduction. I'm someone who does a lot of imaging, so that's probably what you got from my background is echo, which is an ultrasound test of the heart, MRI, which is another imaging test, which we do for the heart. But I also do a lot of work with cancer patients. So I work in a clinic where we're referred cancer patients where there's a concern about heart disease, either during their treatment, after their treatment, and these patients are referred to. There's a few of us working in that clinic, a few of us at the general, and a few of us at the Heart Institute. Okay, so we're seeing patients, and I've seen a few patients with prostate cancer that are referred from some of the radiation oncologists, as well as some of the medical oncologists. So they sometimes get referred. But I would say they make the minority of the cases that I see. So we don't see, and you'll see why they make the minority of cases.
It's right there in all the instructions on.
Oh, there's someone trying to get on?
Yeah.
Okay. Yeah, so that's sort of my background. So yeah, this was a topic. I guess I don't know how you guys heard about this topic. So was there, maybe you can tell me what made you think to contact me?
It was through the patient empowerment program.
Okay.
Rob,
Get on our website.
can't think, Dr. Eliak.
Yeah.
And Dr. Rob Rutledge
Okay.
down in Dalhousie University.
Okay.
They have a group study program that's going on, and one of their monthly presentations focused on the meta-analysis of all of the studies that had been conducted. So we ended up doing the valve analysis with the mobile clinic that came out.
Yeah.
We offered that last summer.
Right.
And then realized, oh, it's just the valve, the arteries that you should be worrying about.
Okay.
So hence that's why we reached out.
Yeah,
and we
perfect.
appreciate you being here. Thank you.
Okay. Yeah, so I thought, given that I'm the first cardiologist, at least I thought I was here, and it looks like I was right. I talked to what is cardio-oncology, which is a sort of a discipline that I work in. I do clinical work, so I see patients, but I also do research in cardio-oncology. Talk about prostate cancer and its treatments. And my disclosure is I'm not an oncologist, so I'm not an expert on those things. So I'll try to answer questions about that. What I am an expert on is cardiovascular disease. So that means heart disease, stroke, those sorts of things. So we'll talk about how common it is in patients with prostate cancer. We'll talk about what are the effects of the drugs that patients receive with prostate cancer and how it affects heart risk, and then we'll talk briefly at the end about strategies to reduce your risk of heart disease while you're getting these therapies. So the first topic is what is cardio-oncology. So it's a relatively new discipline. Actually, one of the very first clinics in the country, probably the first, opened in Ottawa. It was a Dr. Dent, Susan Dent, who's at the time she's a breast cancer doctor, and one of the doctors who's now retired, Dr. Turek, at the General, opened this clinic together, and they were I think it opened in 2010. So it's been around for about 16 years or so. And so what we do with this clinic or this discipline is we want to try to prevent or help manage cardiovascular disease, so heart disease, in patients with cancer, either during their treatment, sometimes even before their treatment, or after their treatment. Okay, so and then you'll see there's a lot of overlapping risk factors. So the same risk factors that cause cancer can also cause heart disease. Smoking being an example, obesity being another example. Okay, and then there's a lot of sort of when you go down to the cell level, there's a lot of shared pathways. Some of the genetics involved with cancer are the same genetics involved with heart disease. Okay, so that lends itself well to research. And then a lot of the work we do, I'm a cardiologist. I don't know that, I didn't train in cancer, so I have to work very closely with the cancer team. Where there's a lot of discussion back and forth, especially when we're trying to decide. A lot of the times I get asked, is it safe for this patient to stay on their cancer treatment? And that requires a bit of discussion. I can give them my side of the story, and then there's a little bit of back and forth. So it's a lot of teamwork between the cancer team, myself. Sometimes there are other teams I have to get involved in the care of a cancer patient. Some of our patients, we refer to something called cardiac rehab, which is probably a program that would work well with what we're going to be talking about today. But it's a program where people work on their fitness levels. They work on reducing some of the risk factors for heart disease, like improving high blood pressure, diabetes, those sorts of things. If any of you have had a heart issue, you'll know about the cardiac rehab program. So that's something that we use in cancer care as well, cardio oncology. Okay, let's go on to the next slide. So there are roughly, at last count, 1.5 million Canadians living with a cancer diagnosis in the last 10 years. About half of them are people who have finished their treatments and they're cancer survivors. Half of those are people who still have active cancer and are still getting active care for their cancer. And many of these patients have about a 3 to 4-fold higher risk of developing heart disease earlier than they normally should. Okay, so they seem to be at higher risk for developing heart disease, stroke, heart failure would be another type of heart disease that we look at. So basically, if someone does develop these issues while they're on their cancer treatment, a lot of times that will lead to interruptions in the cancer treatment, and they may not even be able to complete their cancer treatment. So that's something we don't want. We want patients to safely be able to finish their full cancer treatment and get the best care possible. Okay, so that's something that we're trying to help with in cardiology. Okay, next slide, please. So I mentioned I do research. This is actually the fellow who's done the most research, who you'll see me reference his name several times today, in prostate cancer. He's at McMaster University, Daryl Liu. I've done some work. Most of my work's been in breast cancer, but this is one study I did that I felt was relevant to today's discussion. So it was mentioned I was working in Alberta, and I was there for 18 years. And we did a study where we looked at, over a 12-year period, how many people in Alberta were diagnosed with cancer. And it turned out there was 224,000 people diagnosed with cancer. And then we compared them to the 4.5 million other Albertans who didn't get cancer during that time. And we said, what is the risk of the people with cancer for developing new heart issues compared to the people who didn't have cancer? And you can see we calculate something called hazard ratio. And anytime the number is above 1, you can see that they're at higher risk. So the no cancer group, they were sort of the reference point. So they were sort of our control. And you can see the cancer group for all of the outcomes. So cardiovascular mortality, so dying from a heart attack or a stroke, they're at a 23% higher risk. Developing a heart attack, 11% higher risk stroke, 54% higher risk, heart failure, 73% higher risk, and pulmonary embolism, which is a blood clot disorder, that's a 4-fold higher risk. That's really high, okay? But then we did some other complicated analyses where we controlled for age, and some of these numbers came down, like the heart attack was no longer that significant. But all the other ones were, even after we factored in age and sex, all people with a cancer diagnosis, they are at higher risk for all of these things. Okay, after controlling for their age, their sex, and other factors. So getting a cancer diagnosis does seem to put people at a higher risk for developing heart disease if they didn't have it already. Okay, so let's go on to the next slide. So this group is interested in prostate cancer. Now, we didn't look specifically at prostate cancer, but we did look at a sort of umbrella term, genitourinary cancer, So that would include prostate cancer, probably most of those cancers, but that would also include like bladder cancer, kidney cancer. But most of those would probably be prostate. So you can see there was, a higher risk for death over the 12-year follow-up period for heart-related death, above about 20%. Strokes, 30% higher risk of developing a stroke, about 30% higher risk for developing heart failure. Heart attack was not a higher risk, actually. It was even with the general population, okay? But everything else was higher risk, and then the pulmonary embolism was very high. Okay, so that's it. But again, that includes not just prostate, but other bladder cancer and kidney cancer. So you can see there are some groups that were even much higher than the genitourinary. Like for example, lung cancer group, they were very, very high. And in the past, we wouldn't be able to do much for lung cancer because we didn't really have any effective treatments, and those patients unfortunately would die within a few years. But there actually are some very effective immunotherapies now, and those patients can live much, much longer. So we are seeing these patients with lung cancer live long enough to develop heart disease now. Most of the research. So most of the research up until now has been in breast cancer. But like I said, there is a lot of work that's been done in prostate cancer by a doctor in McMaster. So I'll reference his work a lot this evening. Okay, so let's move on to the next slide.
So, do you want questions at the end?
We can, let's see how we're doing on time. We can ask questions now, sure.
Do you look at the study the studies that were done in Iran that resulted in the
meta-analysis
that said, okay, prostate cancer.
Okay. So Richard, that I will reference meta-analysis coming up.
Okay.
Yeah. This is a slide that basically shows when is the risk highest for people to develop heart disease. And you can see that it's highest in the first year. So hazard ratio means risk compared to normal. So this would be a 2-fold higher risk, a 5-fold higher risk, 10-fold higher risk.
Wow.
So you can see that for some things, the risks are very high, and they're all highest in the first year. But what's important to note is many of these risks persist even out to 10 years. They never come back down to 1, which would be the same level as the general population, okay? So things like heart failure, stroke, these are all that remain pretty high over time, okay? So yes, there's a risk during treatment. Most cancer treatments, maybe in prostate, they can go on for a while, but many of the cancer treatments sort of last for about a year. And it's during that first year when people are getting their chemo where the risk is highest, okay? But then there is a risk that persists beyond that first year, okay? Please, next slide. So this slide sort of gives you an overview of the types of heart issues we see related to the different types of cancer treatments that people receive. And I can tell you that in the clinic, the main question that I'm asked to give an opinion about is heart failure, which thankfully won't be a big issue with prostate cancer that we'll talk about today. But with some of the chemo drugs that are given for breast cancer, for example, or lymphoma, sometimes they're tied to heart failure, which is really a bad condition that you want to avoid. Not that any of them are good, but particularly heart failure is a bad one. But then, there are some things here that have been linked to high blood pressure, that have been linked to heart attacks, inflammation of the heart, which is called myocarditis, arrhythmias, and then blood clots, thrombosis, okay? And if you notice, I haven't put any of the prostate treatments up there, and there's a reason for that, because you'll see in a moment that the prostate treatments, it's not really clear that there's a strong link to any of these things, with maybe the exception of high blood pressure. So we'll talk about that. Okay, so let's go on to the next slide. So we'll talk about, so that's sort of an overview of the discipline that I work in and do research in, cardio-oncology. So now we'll talk about prostate cancer and its treatment. So let's go on to the next slide, please. And again, I'm not an expert on this, but I've read online in Statistics Canada, 1 in 8 men in Canada will develop prostate cancer in their lifetime. I've read anywhere from 1 to 9 to 1 in 8 is down. Yeah. And then it accounts for all, like 23% of all new cancers in men, and it accounts for 11% of cancer deaths in men in 2025. So those are the most recent statistics. So, okay, look at the next slide. Okay, so what are some of the potential causes for people getting prostate cancer? And based on my review, is there some that have been definitely linked to getting prostate cancer and some possible linkages? And so some of the definite ones are, as we get older, we're all at higher risk for developing not just prostate cancer, but many different cancers. There also seems to be some genetic predispositions to prostate cancer. We know that some ethnicities are also more at risk for developing prostate cancer, in particular Black men. And then obesity is another link to prostate cancer. In terms of possible causes that, there's some studies saying yes, but maybe less convincing than what I've just talked about. So having higher testosterone levels, having inflammation of the prostate gland. So people that have, inflammation or infection recurrent, there may be a link to prostate cancer. And then there's some evidence that diet may also play a role. So people who eat a lot of meat, dairy, so processed meat in particular, and those things we also see linked to heart disease. I mentioned earlier, there's linkages, obesity, genetics, diet. Certainly these are things common to heart disease as well. Okay, so it's not surprising that we're seeing the two, cancer and heart disease, go together often. Okay, next slide, please. So, and again, I'm not an expert on this either, but these are different stages of prostate disease. So you've got early stage disease in the upper left corner there. So about 21% of the time, when someone's diagnosed with prostate cancer, they have the earliest stage disease, stage 1, but most of the time it gets detected at stage 2, where it's still pretty localized, but it's bigger than stage 1. 19% of the time it's stage 3, so it's in the prostate, but then it's also starting to work its way out of the prostate into some of the glands right next to the prostate. And stage 4 is the highest stage where the prostate cancer moves elsewhere in the body and goes to like bone, for example, like to the vertebrae. Okay, so that's the most advanced stage. Thankfully, that's only seen in 9% of cases initially. Okay, we'll go to the next slide. So the survival for prostate cancer, the 5-year survival is excellent for if you're diagnosed in one of the first 3 stages. The treatments seem to work very well. So there's virtually 100% of people. Don't ask me how it could be 101%, but anyway. This came from the Canadian Cancer Society from their website. So yeah,
Easter.
yeah, sure. Yeah, so it probably should say 100% for the first 3. But if you're in stage 4, the survival is lower. So once it's spread beyond the prostate and goes to like the bone, then that's when they start to see decline in survival. Okay, we'll look at the next slide. So basically, there are 3 main types of treatment for prostate cancer. You can have surgery, radiation, and then there's some drugs. And so today I'm going to be mainly discussing the drug treatments for prostate and the links to heart disease. There hasn't really been any research, to my knowledge, in prostate disease showing a link to radiation of the prostate and heart disease. There is a radiation to the chest and heart disease, which is why I work in breast cancer, because they get radiation to the left breast. But in prostate, to my knowledge, there's no link between radiation and heart disease, and same for surgery. This is robotic surgery, an example there. But the drugs, there has been links, and that's what we're going to talk about today. Okay. So does anybody know the drug treatments, the medications that are given for prostate disease or prostate cancer? What is the main thing that's being targeted? You guys?
Testosterone.
Testosterone, exactly. Okay, so hit the next button and to see, so yeah, so so that's testosterone there. So that's what is being targeted. It's testosterone. So, okay, great. So we'll go on to the next slide. And what are the effects of testosterone, let's say normal testosterone in the body? And apologies if you already know this, but it does do a lot of things in the body. It can affect mood, libido. It increases muscle. So obviously, some bodybuilders are using testosterone. It can also stimulate blood production. So people have used it to have higher levels of hemoglobin, which is the main oxygen carrying molecule in the blood. It also helps bone growth. It helps as well with erection. And it helps with, you get more skin hair and balding from having testosterone. And we'll look at the next slide there. So what happens if you have low testosterone? Because remember, the drugs that are being given in prostate cancer, those are being given to lower either testosterone or lower the effects of testosterone. So those patients receiving those drugs, they see some of these effects of having low testosterone. Okay, and so some of the effects relevant for what I'm talking about today is they will have reduced muscle. They may have reduced muscle mass because of having lower testosterone. They'll have more body fat. So that's what you're seeing there. More brittle bones. So basically from the heart end of things, what you need to know is there's some changes in our body composition that unfortunately make you more susceptible to heart disease, okay? The main one being fat. You retain more fat. So you lose muscle and you get more fat, which is a bad trade-off. We want to have the opposite happen, okay? So we'll go to the next slide. And so the treatments for prostate cancer, they target different areas of the body. The main drug that's given for prostate cancer, which I'll show you in a moment, it targets the pituitary gland, which is a gland in the brain that releases hormones that help with the production of testosterone, okay? So if you block this gland from releasing those hormones, then the body makes less testosterone. Okay, and so that's one of the main areas of the body that these drugs target. Okay, good. We'll go to the next slide. And so these are a list of the drugs that target that gland. And the main one that I've seen given and that I read in the internet, the main one given, and that's also true from my experience from what I've seen, is this Eligard. Okay, so Eligard is a medication that, again, it's an injection. I think it's given like every 3 months. They go in and get an injection for it, and it targets the pituitary gland, and it's an agonist, which means that it's overloading. It's giving so much information to the pituitary gland that the pituitary gland becomes overwhelmed, and it stops releasing that hormone. Okay, but then there are other drugs that directly block the pituitary gland. So you have some that overstimulate it, and others that block it. But the main one that's given is this Eligard, is that overstimulation one, and that's I think partly it's given because it has the most data showing that it works well to help maintain that 100% survival rate that I showed you guys earlier. Okay, let's look at the next slide. So we talked about, some of the drugs target the pituitary gland. Other drugs target the adrenal glands. The adrenal glands are glands in sitting on top of the kidneys. Those also make testosterone. So these drugs target the brain. They target the adrenal gland. And then the last place that they'll target is the receptors in the prostate. So there's something called androgen receptor inhibitor, so testosterone receptor inhibitor. So those is another area that's targeted. So really there's 3 levels of targeting for prostate cancer. There's the brain, the adrenal glands, and then the prostate. Okay, so those are, but as I mentioned before, the main drugs that are given are at the level of the brain. It's the pituitary gland. Okay, we'll do the next one. And so these are some of the drugs that are given to target the adrenal glands as well as the prostate. Okay, so these are the ones targeting the prostate. These are the ones targeting the adrenal glands. Okay, so the cancer doctor who's treating these conditions, prostate cancer, they have many different drugs at their disposal that they can use. And I'm thinking the main way they'll decide, they'll probably usually start with the Eligard, with the first one I showed you. Unless there's a reason they can't give it, or it doesn't seem to be working as well, they'll switch to some of the other ones. But again, I would defer to one of the cancer doctors when they come and tell you about it. We'll look at the next one here. Okay, so thankfully we're going to get to things I am an expert in. So we'll talk about heart disease and you know how it's linked to prostate cancer. So let's look at the next slide. So how common? So even before someone with prostate cancer receives these drugs, how common it is for us to see heart disease in these patients? Well, already before getting any of these drugs, about 20% of patients with prostate cancer have heart disease to begin with. Okay, and if you remember, I mentioned there's a lot of shared risk factors, obesity being one, between developing prostate cancer and developing heart disease. So this is these are some very large studies, some of them that I've listed here, and you can see that the prevalence or the frequency, the rate of heart disease, you know, ranged anywhere from 16% up to 27%. So on average, it's about 20%. So approximately 20% when the patient walks through the door, about 20% of them will have heart disease even before getting these treatments. Okay, so they've had a heart history beforehand. Okay, great. And this is the doctor I mentioned, Dr. Leong, who's in McMaster, so in Hamilton. So this is one of his publications. Okay, let's look at the next one here. So this is one study that he's done, Dr. Leong. You can search it up. It's called the Radical PC, Radical Prostate Cancer Study. So it's a Canadian led study sponsored by CIHR. And he asked the question, how does the rate of heart disease compare if you're receiving one of these prostate cancer drugs versus prostate cancer patients who are not receiving these drugs? So the blue columns are patients who are receiving the prostate cancer drugs. The white columns are the patients with prostate cancer who are not receiving the drugs. So you can see here that the bars are pretty close, but the blue bars, so the ones receiving the drugs, are a little bit higher in most cases. So if you look at things like Framingham, which is sort of a combination, it's a score we give patients for developing heart disease, so they include things like high blood pressure, cholesterol, diabetes. So that score is higher in patients receiving those drugs if they're not. Cholesterol was about even. Smoking was higher in patients receiving the drug. High blood pressure was slightly higher. Obesity and diabetes were probably the two things that were the most high, okay, and were the highest. And that shouldn't be a surprise because we talked about, you know, that those drugs and low testosterone are linked to more body fat, okay, and diabetes is linked to body fat. So that should not come as a surprise. So those are risk factors, and then you can see patients on these drugs that had higher history of heart attacks. So even though I showed you earlier that it looked about equal, this study suggested that they were similar. The one thing to know, though, is later on he did a better job of controlling for age. Once he controlled for age, because the people receiving the drugs were older than the people who were not receiving the drugs. So once he controlled for age, a lot of these things sort of leveled off. Okay, so okay, we'll go to the next one. Okay, so this is a different study done by, I believe, an American group, and they looked at what are the most common causes for death in patients with prostate cancer. So if you follow them over time, so this is within 1 year of diagnosis, 1 to 5 years of diagnosis, 5 to 10 years, or 10 more years. It's hard to see, but the purple, so the maroon bar represents heart disease. So you can see that, and all comers, the leading, and I'll specify, these are in patients who have stage 1 to 3 prostate cancer. So this is not advanced, okay? So if you had early prostate cancer, you were more likely to die over time from cardiovascular disease than from your prostate cancer, okay? Which maybe is not a surprise in a way, because the prostate cancer I showed you, the treatments work actually quite good. You know, I'd love to have a heart treatment that's 100% effective. I don't have that, unfortunately. Okay, we'll look at the next slide. Okay, so now we're going to talk about, and we're getting into probably the most important part of what we'll be talking about, which is what is the risk of the cancer drugs on heart risk, okay, on your risk for developing heart disease. Okay, so these are some of the main things I want you to take away from today, is that the effects of receiving these drugs. So if someone with prostate cancer is prescribed these drugs, they have some studies suggest on average or up to an 11% increase in their fat mass, 60% higher risk for developing diabetes compared to if they weren't getting these drugs, 80% higher risk of high blood pressure. Okay, so those are some numbers to keep in mind. Okay, and we'll look at the next one. So this is again the same doctor in Hamilton. He did a study where he looked at close to 4,000 men with prostate cancer. So about half of them were receiving the drug, like to lower testosterone. So most likely it was Eligard. Half of them were not receiving, and he looked at how they did over time, and he found that on average, if you were receiving those drugs for 12 months, you had about a 2% increase in your waist circumference on average, and a 27% loss of your hand grip. Okay, so they're losing muscle and they're gaining fat, and these are hard to see, but basically the people these are separated into quartiles of hand grip loss and quartiles of waist circumference gain, and the people who gained the most waist circumference or lost the most hand grip strength, they were at the highest risk for developing heart complications over time. Okay, so they were followed for 36 months. So the ones who, so this is the average, but let's say your waist circumference increased 10%, well, you were at much higher risk for developing a heart issue over time versus the ones who didn't gain as much. Okay, great. So look at the next slide. So this is a meta-analysis, and this is one of the meta-analysis which kind of makes us less convinced that there's a direct link between receiving these medications and them directly causing heart disease. So this was a meta-analysis you can see of 7 or 8 studies, I believe. And the main thing to note is this diamond at the bottom is very close to 1, which means that there doesn't seem to be a higher risk of developing heart issues compared to not being on this drug. So you know, and even today, like even if you read the work done by Dr. Leon, he's also not sure, or no one's really that 100% convinced that the drugs are directly linked to heart disease. Okay, what they are linked to, we'll look at the next slide. Actually, before we talk about that, okay, what about this is this is good. No, it's good. So this is another meta-analysis of 11 studies now, comparing different types of prostate cancer drugs. So I mentioned at the beginning, there are two types of drugs for the pituitary gland, one that overstimulates it and one that blocks it. And this study suggested that the one that blocks the pituitary gland seems to have less risk for heart disease than the one that overstimulates it. Okay, but then I can tell you after this study, so this study was published not that long ago, 2023, but there's an even more recent study called the randomized controlled trial, which they had to stop it early because they were having so few events. They were following patients over time, and they were not having very many, thankfully for the patients, they weren't having very many cardiac events. So in the end, they weren't able to see a difference between these two types of therapies. So again, it makes us less concerned about developing heart disease, at least in the time frame, in the, let's say in the 5+ year time frame of these studies. Okay, we'll look at the next slide. Okay, so this is the last part. This is the most important, is strategies to reduce the risk of cardiovascular disease. So let's look at the next slide. So, basically the take-home message from today is I want you to think of these drugs as putting you at greater risk, or the person at greater risk for developing obesity, developing diabetes. So obesity is linked to diabetes. Obesity is linked to high blood pressure. Okay, so look at it as not really a direct link to heart disease, but it's a link to risk factors for developing heart disease down the road. Okay, so these are things, so these are recommendations that we give to patients to prevent developing heart disease. And this is what, patients on these drugs should think of it the same way. Is my blood pressure well controlled? Am I getting enough physical activity? Am I getting 150 minutes a week of physical activity? For most people, that's going for a walk. So I recommend 30 minutes a day to my patients. Aspirin use is controversial. It doesn't really apply to this group. Diabetes, though, that's definitely applicable. So that's something you have to make sure you're on effective treatments for diabetes. Diet, we talked about. So generally for heart disease, we're emphasizing. So what I tell my patients is when you look at your plate of food in front of you, half of the plate should be fruits and vegetables, a quarter should be protein, a quarter should be whole grain. Okay, dairy doesn't figure into it all that much anymore, to be honest. Tobacco, obviously, you want to try to quit smoking. There's lots of effective tools at the Heart Institute. We've got a whole team dedicated to helping people quit smoking. And then there are some more advanced testing we can do. Some people get testing called calcium scoring to help us decide if they're very high risk for heart disease or lower risk. So there's special tests we can do. Okay, we'll look at the next slide, which I think is coming towards the end. So this is sort of my summary slide. Okay, and this is again from Dr. Leon. I thought it was a nice slide. So the way to think about prostate cancer is it's not the prostate cancer itself that puts people at risk, it's the treatment that they receive. And so it's these agonists which are stimulating the pituitary gland. Then there are these other drugs which block the effects at the prostate or block at the level of the adrenal gland. These drugs put people at risk for obesity, for diabetes, and high blood pressure. That's what I want you to take home from this. Yes, that can lead to heart disease down the road or stroke down the road. So far, the studies, maybe they just don't go on long enough for us to see it, but definitely we're seeing the obesity, the high blood pressure, and diabetes. And then in terms of how we treat it, it's the same advice that hopefully family doctors and we are giving people to prevent heart disease. So it's making sure your blood pressure is controlled, getting your cholesterol checked, eating a healthy diet, doing physical activity, quitting smoking. And then in some people who already have heart disease to begin with, like I mentioned, 20%, we were even stricter about blood pressure control. So if someone has heart failure, we're even more careful about making sure their blood pressure is under control, okay? Because we don't want their heart failure to get worse. Okay, great. So that's the summary slide. So that's it. So this is Spiller's Cove. I had the opportunity this fall to travel to Newfoundland. I've never been there before. So I'm almost 55, and it was the one province I'd never been to. So I got to go there for a conference. And my wife and I, we got to go hiking. There's some beautiful trails there. So if you ever have a chance to go there, we were off season like October. I wouldn't be the ideal time to go for most of that time. But in the summer, in June, I think there's whale watching you can do there. And so it's a bit out of the ways to get to, but if you ever have the opportunity to go there, I'd recommend it. It's a lot of fun. All right, anyway, happy to take any questions.
Okay. So, can you?
Yeah,
Hi.
so question, thank you so much
Yeah,
for
sure.
this, really
Excellent.
appreciate all of us,
Yeah, sure.
because I think most of us on ADT. Now, the question I have, I'm not saying, anything, bad about it.
Yeah.
But when I hear about Liang study, it's doing really good and the numbers showing really very relevant for us.
Mhm.
But when I hear like 40,000 in this study or something like that, my question is that, is the study, survey study or clinical? Because if I the survey is kind of difficult. If I'm one member of that survey study,
Okay.
I wouldn't be able actually to report everything right. Maybe 10% right and the rest of it just I forget, I don't know what to do. So how much faith you have in this study, survey study? Okay.
So a good question. So these studies that I showed are not surveys. Okay, so these are studies. So the study that I showed, for example, of Dr. Liang, where they were measuring body fat and hand grip strength and blood pressure, those patients were coming in to have those measurements performed. Okay, so those were we call those longitudinal studies or cohort studies. Okay, so those were and I believe it was a multi-center study. So there were many different sites. We did not participate in his study, but he had, I believe, I'm trying to remember the sites, but there were definitely at least 5 or 6 Canadian sites, and there were even sites outside of Canada who participated. So they would have, each site, let's say, would have contributed a couple hundred patients or a few hundred patients, and they were coming in to have these measurements performed. So they would come in, so they would sort of measure it at start of the drugs, and then at 12 months, and then they would follow these patients for a period of time to see if any of them developed heart issues. And so they followed them for 3 years.
I have two brief questions. If I may just perhaps in 25 words or fewer, just summarize. Most of us, I think all of us, are prisoners, I guess, of this form of treatment. We have no choice at the moment. So in terms of the additional risk, clearly you're saying there is an additional risk, but that this is manageable through observance of the aspects that you've highlighted, that essentially we shouldn't go sleepless tonight because of this presentation. That's really my point here, that this is something that we can manage with, that it's a warning, a caution light, but something we can manage, nothing we should be terrified about.
Yeah, that's an excellent point. So there's that's a very good point. Some of the cancer drugs that are given to patients, they can cause very sudden changes in the heart. That's not what we're talking about here, though. For prostate cancer, these changes are not even to the heart, they're to the body, like causing extra fat. So these are very gradual changes that happen over time. So these are preventable, like if you live healthy lifestyle, they should be preventable in most cases. Okay, so you're absolutely right. I would not be losing sleep over this. It's something that requires some attention, though. Like you need to be vigilant. You need to monitor your diet, your physical activity. If you already have high blood pressure, diabetes, you need to be extra vigilant to monitor these things if you're on these therapies.
My last question is this. A friend of mine rather bluntly described the treatment we're receiving as trying to turn us into a girl. Now, we can chuckle at that, but the point is testosterone. Is the reduced testosterone the culprit? And the reason I ask that is, I mean, Is my wife at risk? I mean, apparently this is sort of like menopause-inducing similar treatment. Is this the feature of testosterone as being beneficial to cardiac health, or is it the medication for some other reason?
Yeah, so as far as we know, or as far as I know, the reason for the high blood pressure and the extra fat, that's due to having low levels of testosterone as a result of receiving the medication. So it's not, so that seems to be the mechanism that most people think. So in terms of women, you're right that when women reach menopause, what we usually see is their risk of developing heart disease starts to approach that of men. Before menopause, they're at lower risk. We think it's related to beneficial effects of estrogen on cholesterol levels on one hand, but then after menopause, their risk approaches that of men. One of the messages I don't want you to get is coming away from here thinking more testosterone is beneficial for the heart or heart disease. That's not true. You're better to have normal levels of testosterone. Having high levels brings its own problems too. I've seen patients taking anabolic steroids who develop heart failure or really bad high blood pressure. So you don't want to have too high levels of testosterone. You don't want, in the case of people receiving prostate cancer treatment, yes, the levels are low, but it's what's keeping that prostate cancer under control. But what it means on your end is that you have to be, extra vigilant with all the things I've mentioned.
Thank you.
Yeah.
Thank you.
Go ahead. So if I understood the study correctly, it was 12 months of ADT therapy and then following the patients and for another 2 years or 3
Yeah,
years,
exactly.
something like that. Were the patients on ADT that entire time, or they were?
Yes,
And does many men stay on ADT for many years?
correct. Yeah.
And then what is the cardiovascular effect after many years of treatment? Presumably it increases, but do we know how much?
Correct. So I think that's the gap in the knowledge right now is a lot of these studies, they perhaps are not following people long enough. And that you're exactly right about that. So 3-5 years may not be enough. You'd have to follow people 10, 15 years before you'd start to see the downstream effects on these people developing heart disease. So I think that's a good point. Yeah.
And I guess just a quick follow-on. One of the strategies now is intermittent therapy. So patients go on ADT for 9 months, 12 months, and then go off until the PSA goes back up to a certain level and then goes back on. And that would be another area of interest is that, what's the impact of that on not only heart disease, but the other adverse effects, long-term adverse effects of ADT?
Yeah, and I don't know, but that would be a very interesting study. Yeah.
Well, just as you were talking, I was thinking along that same line there, because oncologists manage the use of ADT across a spectrum. In my case, for example, I was stage T2B. I did brachytherapy. I did 15 sessions of external beam, but they put me on ADT for 6 months.
Okay.
And that was the end of it. Other people may have to go on it for like 8 months or 18 months or 24, but they stop. And they wait until perhaps maybe the PSA starts to rise, and then they may have to go on it again. I wonder if the studies took account of that, those lapses in the presence of those drugs in people's bodies. For example, I wonder, okay, I was on it for 6 months. Am I looking at residual effects possibly for myself, and for how long?
So, okay, so a couple of things, I guess, related to that. So, what I don't know the answer to, because again, we said it looks like these effects are related to low testosterone levels. So if you receive it for 6 months, during those 6 months, I would imagine your testosterone levels are lower.
0.
After the 6 months, when you're off the medication, what happens to testosterone?
My testosterone came back to normal.
Okay.
And my PSA has stayed below 0.02. I'm only one example though.
So
other people, by the way,
yeah.
are on what's called intermittent ADT.
like 6 months on, 6 months off, or a year on, a year off kind of thing. There's quite a spectrum of different methodologies that the oncologists decide in each case to administer.
So what would be an interesting study would be to look at risk of developing these complications related to duration of treatment, so that's something that could be done. Again, in my reading, I didn't see anything like that, but that would be interesting to do. I guess the other thing is if someone's testosterone levels come back to normal after getting the treatment, I think from a heart prevention or the point of view, that's good. However, if they did develop more obesity and while on those 6 months, they still have to get rid of that problem, right?
Yes,
So,
I know.
Yeah.
I'm working on that. We all.
Yeah, so, go ahead.
What test would you suggest we seek out to have an evaluation of our cardiovascular health?
So I think, so the excellent question. So I think the main thing would be risk factors for heart disease. So that would be measuring your blood pressure regularly, having your cholesterol checked, having your blood sugar checked for diabetes. These are things really the family doctor or general practitioner.
And that's typically what an oncologist will do, to say, that's out of my bailiwick, go convince your doctor to,
Right. And
your regular physician.
And I think that's, something, blood pressure now, I have a blood pressure machine at home. Some of you may as well. You can check that yourself, to be honest, or go into the pharmacy and get it checked. But yeah, for the blood test for blood sugar and cholesterol, you need to get in to see a family doctor or a general practitioner. Yeah.
And how frequently?
Yeah, I don't know that there's good data on that. So for blood pressure, it depends. If someone already has high blood pressure, I would say that they should be monitoring that. I don't know, let's say, it depends if it's well controlled. If it's well controlled monthly, let's say, if it's not as well controlled, more frequently, so weekly, let's say. For cholesterol, nowadays, I'm told that family doctors will check it once and they won't check it again in many cases. Same for blood sugar. Whereas in the past, they used to do it every year, and now they've decided that there's no good data to support doing that anymore. So, but should that change for somebody on these therapies? I don't know that we know the answer to that question. So what I'm getting at is, does monitoring this more frequently in patients make a difference to their outcomes? We actually don't know that. So, so in the absence of evidence, I could tell you, maybe have this checked once a year. Certainly, if you're noticing some significant weight gain over this time, that would be an even stronger reason to go get it checked more frequently. Like, I wouldn't do it more frequently than once a year, though, like for the blood sugar, the cholesterol.
Yeah. Okay, thank you.
Yeah.
Doctor, thank you for your presentation. I appreciate the time that you're spending with us tonight, for sure. You did clarify one thing for me that I found interesting, in that I'm 60 years of age, and I've been on ADT and those drugs for 8 years. And I always with the belief that somehow these drugs were taxing my heart somehow, were a burden of sorts. But you clarified something for me in that it's really the morbidities, the physical morbidities that burden the cardiovascular system. And that's how the heart becomes a victim of these drugs as well. I have a cardiologist, and as part of my team, I've had him for many years, and I think that he's one of the most important members, along with the oncologists that treat me. He's a very important member of my medical team. One of the symptoms that I'm experiencing that's getting worse in the past few years is a shortness of breath. I'm not overweight. I've been reasonably active, but I should always do more for sure, but that's becoming a real issue for me. And the reason I'm saying that is that my cardiologist is doing tests, and it seems to be, everything seems to be all right, and my blood pressure, although high, and is controlled. Probably I'll be seeking a lung expert to investigate potential lung disease. And my question to you is a bit, perhaps, you may not be the right person for me to ask, but I thought I would. Do you have any insight in terms of a potential link between all these morbidities and a prolonged ADT, and somebody like me who's getting 2 medications for ADT for the last 8 years, and how difficult it becomes for the body to live through this? So heart, lung, do you have any insight on this?
Yeah, that's an excellent question. So as I mentioned earlier, most of my research has been in breast cancer. There are some parallels though with what you're describing. So, the fact that these cancer survivors, they don't feel well afterwards. It takes them years to come back to the level of exercise or that they were able to do before their treatment. So I've actually done some research with experts in exercise physiologists. So these are people who are experts about exercise. And one of the things we're noticing is that the muscles are not the same in some of these cancer survivors. So I'm talking about like the leg muscles. They're not the same quality as they were before. So so we talked about gaining fat in the belly. Some of these cancer survivors are gaining fat in their muscles as well. So it's not the usual healthy muscle. There's marbling, a lot of fat marbling in some of these muscles afterwards. And I've done some research that shows the more of this sort of fat marbling you have, the more easily you get tired when you exercise, or more out of breath. Now, how you treat that? Good question. We don't really know, but I would assume the same things we've talked about would apply. So if you're, eating more healthy and getting more regular exercise, I would assume that this fat in the muscle would improve, but I don't have proof to tell you that for sure. So I don't know the specifics of your case. I don't want you to think I've made a diagnosis. I'm just speaking in general terms, that when we don't find a heart reason or a lung reason, we start thinking outside, and one of the other explanations could be, the muscles that move us when we walk. And so maybe the issue is there. Yeah.
Thank you. That's interesting. I'll investigate that, and thank you very much.
Yeah.
Malcolm,
Yeah, so I was on ADT for 2 years, and I also got older by 2 years. So I'm wondering, it's trying to correlate that versus just the aging process. Now, I definitely know I don't have the same muscle capability as I probably had 5 years ago, but is part of that the treatments? Part of that just naturally aging? Because I think most of us will get it that as we get over a certain age, we can't do those things that we used to do. So I just went along with the treatment saying, I'm alive, it's keeping me alive, at least stopping me from getting cancer, which it seems to have done. So yeah, I think the diabetes thing kind of snuck up. But then I talked to my sister, who's 2 years younger than me, and she said, oh, have you got diabetes like our mum and our grandmother? And so then I'm going, well, is that the drug? Is it just the genetic thing sneaking up on you? These are all so many conflicting factors, and it's very difficult to get any doctor to come and sit down and say, yeah, that's because of that, that's because of that, and that's because of that, because it can't be, right? So I think you're right about the exercise thing. I tried to do the exercise, but I know I can't lift something the same way as I used to be able to lift it, and I probably can't run anymore, but I can still walk a lot and do what you can. I think I'm not a gym person, never was. So for some people that's great, but for me it doesn't work.
So the comment I'll make relative, so in heart disease, when we've talked about exercise, and I was guilty of this a few minutes ago, we've tended to focus on endurance or aerobic exercise and not as much on resistance training, you know, like keeping your other muscles.
Yeah.
And I showed you that study from Dr. Leon where he showed that the hand grip was actually a good measure of fitness and it was linked to risk of heart disease over time. I don't know that we fully understand that. Like, I will say though, now I'm trying more, not just to emphasize the endurance part of exercise with my patients, but also the resistance part as well. We know people as they get older, they're at risk for falls, and that's unfortunately how, and if you have more brittle bones from low testosterone, for example, you could have a fracture more easily. And we know getting fractures, hip fractures, puts you more at risk for death. So these are definitely things you want to avoid, if not from a heart prevention, just from an overall health prevention.
Yeah, so like you mentioned the diet
Yeah.
and the cholesterol actually many times, you
Yeah.
know, the link between, you know, heart disease and the diet.
Yeah.
So my question, because I think we had a chance to ask the expert here, like the diet pyramid now, from what I see, they reverse it actually. They put the meat and the fat at the top. They said eat those, they are good for you, you know, reduce sarcopenia or whatever,
Yeah,
keep
yeah.
your muscle.
Mhm.
So that's actually, like, now we are confused. Another one, which is really from good doctor online, I know they are good, I actually don't listen to anybody. I
Mhm.
search where they belong, where they work, and some of them, they're incredible. They say cholesterol is not really the culprit for this, it's not the problem, because the body can make 3.6 grams every day. So how do you start the body from cholesterol to breathe something? You're gonna create more problem. What do you say about this? Like, where do we go? With this information from?
I think, yeah, so I think you're right. I think there's a lot of truth to what you're saying. So in the past, we used to tell people to avoid red meats because there's cholesterol. I think we still are telling people to be careful with red meat, but you know, there's some meats that have less cholesterol than others. So fish being an example. How you prepare meat also is important, whether you know you're deep frying things versus baking. Like if you bake, it's probably the healthiest way to prepare meat. But like I said, meat is linked to muscle, and muscle is linked to overall good health. So that's important. When I see a patient who needs to lose weight and they ask me for advice, you know, the ones who have had the most success over time have been the ones who have been the most careful about their carbohydrates. So those are, if you have a drink, being careful about sugar. So things like tea would be fine as long as you're not adding sugar. You know, things that have a lot of sugar, drinks that have a lot of sugar are actually juices. So orange juice or things like that, there's a lot of sugar in those. So you're better off drinking water and eating an orange than drinking orange juice. There's just so much sugar in there. Pop, obviously a lot of sugar. So you just want to be careful with drinks. And then you're right that the body makes cholesterol. So if we lose fat, it's just going to lead to all kinds of improvements with the body's metabolism and being able to metabolize sugars and things like that, which are all linked to cholesterol, diabetes. So really weight reduction is at the crux of it for most people, not everyone, but for most people. And I tell people, look, just be very careful with carbs. And the easiest thing is looking very closely at what you're drinking. There are other sources of carbs, like bread is a big source of carbohydrates. So a lot of us eat a lot of bread, potatoes, rice. So I tell people just be mindful of how much of that you're eating. Really, most of your plate, half of your plate should be fruits and vegetables. And in the past, I don't know about you, but growing up as a kid, half of my plate would be carbs. You know, it wasn't fruits and vegetables, it was carbs. So that's what I think the focus should be. Would physical castration be more favorable compared to chemical castration from a heart disease regard. And, you know, I'm not sure. I don't know that anyone's looked at that. Most castration, as you know, for prostate is not physical. It's drug. Although my understanding is that's how they discovered low testosterone was good, but some patients actually did have castration for I guess because of spread of their cancer, and they noticed that it was beneficial for controlling their cancer. I think the key here, like I said, is low testosterone. Low testosterone we know puts you at risk for accumulating more fat. And so I wouldn't think that whether you have low testosterone from physical castration or chemical castration would make a difference. You could still low testosterone. At least with the chemical castration, I guess you can turn it off. Like we talked about intermittent chemical castration, which maybe would be beneficial for preventing heart complication or risk. Yeah, physical you can't turn off, you know, like so.
I think
Okay, thank you.
Barbarism of the thing, you know?
I'll note, Doctor, here that a couple of folks left some comments. Bernie Geiger talking about Orgovex being a much more common pill, and I'm hearing that from some of the guys that come to us.
Okay.
That's Regulovix or it's a tough one.
Yeah. I mean, I would still look at it the same as the agonists. So, you know, it's still androgen deprivation therapy. It still causes low testosterone. It still puts you at risk for all the things we've talked about tonight, which are accumulating fat, more risk for diabetes and high blood pressure.
It's not an ARPI though. It works by shutting down testosterone growth from the testicles.
Yeah, for blood sugar. So I guess, I mean, if you had access to blood sugar kits at home, you could monitor it. Although most of the time, what we like to do as physicians to check for diabetes, there's a blood test called A1C, which checks your blood sugar over a 3-month, like how has it been over the last 3 months? Well, that's an A1C. That's sort of a better, you know, in measuring a blood sugar at one time point, you may miss a level that's high, but so the A1C is nice because it sort of gives you an average of what it's been over the last 3 months. So that's one that I would prefer if I'm able to check it on a patient.
A1C?
A1C, yeah.
Have you looked at all, or is anyone looking at the role of GLP-1, so the Ozempics, Wegovys, et cetera? They treat diabetes, they help promote weight loss. And particularly with patients taking these ADTs or who may be obese or overweight and have concomitant diabetes or other heart disease.
So yeah, excellent question. Yeah, we'll have to get you to help with our study designs. But I was at a meeting with Dr. Leong in November in Toronto. And I think he's interested in it because he seemed to have a lot of knowledge about it. So my guess is he's starting to look at it. So for people that aren't sure what we're talking about, so these are Ozempic, these are drugs that you inject, and they help with fat reduction. There are now oral forms of Ozempic being tested that could be coming to the market soon. So it would potentially replace the injectables if they're found to be beneficial. The one concern that I had when I was reading about these drugs is that there had been some link not only to fat reduction, but sarcopenia, losing muscle mass, as well as in addition to losing fat. But then when I talked to Dr. Leong, he was pretty vehement that he didn't believe that or that there was a reason why that they were losing the muscle mass. He didn't think it was a concern. I think so he thought, I think there were ways to mitigate against that. So that was sort of on the surface my concern. Anyway, so I guess it's to be determined. Like we don't know yet. but I think that would be an interesting concept, like, if someone knows they're gonna be on ADT for many, many years, and they're experiencing, these weight gains, and they've tried their best to control it, and they're not through diet, and they're developing diabetes or other things, then yeah, I think that would be potentially a great option, yeah.
But it's not covered, it's a drug that,
It's not covered for
Not
weight
covered.
loss, it's
No.
covered for diabetes, though.
but would it be covered, well, I guess you don't know whether it'd be covered to help out with the issues that
So
are surfacing here.
So someone would have to do a study to show that it's beneficial,
Yeah,
and then the government would have to agree to pay
And that-
for it,
yeah,
right? So,
right.
and so those are two big steps. So one is, the science to back up doing it, and then the government agreeing to pay for
Right.
it. Yeah.
Some insurers are covering these drugs for patients with a BMI over 30
Okay.
and heart disease.
Yes.
So you have both of those things that can be covered.
Yeah, I have a question about, organ vets. And whether that has any, cardio-related, side effects.
So, I mean, pretty much all of the medications that are used to treat prostate cancer, I would view them the same way. So they all lead to lower testosterone,
Right.
which puts someone at higher risk for all of the things that we talked about. But related to heart, it's that they're gaining body fat, which would put them at risk for diabetes and higher cholesterol and high blood pressure. And those things, many, years down the road, put you at higher risk for heart disease.
Before prostate cancer, I was very healthy. Is no any issue in the family and stuff. But the last CT CAT scan I went for check that is a routine that they show that's a big artery, a little blockage, and the damage. I want to know that would be cause, and I read a lot about that. It say calcium may be cause that too. I stopped the calcium that I take it because the bones supposed help the bones. I was on the calcium for 3 years. I want to know that is a medication cause that, and what suppose I have to do that for this blockage and stuff.
Yeah, so those are good questions. So a question about calcium in the arteries. So that's not, as far as we know, not related to the calcium that we eat. So what happens there is people who develop, originally blockages in the arteries start off as cholesterol. And over time, the cholesterol can become inflamed. So there can be cells that go in there, immune cells that cause inflammation. And then that can eventually turn into calcium. Okay, so the combination of cholesterol, immune cells over time can harden the arteries and become calcium. So it's not coming from the calcium that we eat or calcium that we're taking. It's just something that happens over many, many years. We're talking about decades, where someone's artery, if they have a blockage from cholesterol, can turn into calcium. So that's what I would think about there. So we sometimes will do calcium scores in patients to help us decide if they should be on a cholesterol lowering medication or not. If you do have a lot of calcium in your arteries, there's a higher likelihood that you would benefit from being on a cholesterol lowering medication. So that's something that you can talk about with your doctor. That would be, and then if you've had, damage to your heart, then you may also benefit from being on low dose aspirin, which is something was on one of my slides earlier. No, I guess what I don't want you to come away thinking, oh, I have calcium in my arteries, I shouldn't be eating calcium anymore. That's not how they got there. They got there from inflammation over decades. So if you're taking the calcium for your bones, I think that's important. Most of us, you'll get calcium if you're spending some time outside. You get vitamin D, and then calcium, you can find it in some meats or dairy products as well. So that would be sufficient. But if you're calcium deficient and your doctor's recommending it, I think it should still be safe for you to take. It won't lead to more calcium buildup in your arteries.
Just one quick, you, in addition to mentioning about prostate cancer
Yeah.
having a higher risk for cardiovascular disease, you also mentioned, if you had lung cancer and you had radiation for the lung cancer, does that, which is my case, does that mean it doubles up?
So lung cancer, it's not just the radiation, but so it's probably a bunch of factors. So not always, but a lot of people with lung cancer have a history of smoking as well, which puts them at higher risk for heart disease to begin with. Some of the therapies that people get for lung cancer, so you mentioned radiation.
Yes.
That's if it's on the left side of the chest where the heart is, that could put them at higher risk. Usually the complications from radiation therapy, tend to happen 5, 10, 15 years, in some cases 25 years after the treatment.
Okay.
There are some new medications they give to treat lung cancer called immune checkpoint inhibitors. Those have rarely also been associated with inflammation of the heart muscle, which is a very feared complication. Thankfully, it's very rare. It happens about 0.1% of the time.
Okay.
But when it does happen, it's a big concern, and they call us right away because it's life-threatening.
There's a member of our group that approached me to ask like a write-in question.
Yeah, sure.
Now, this will sound a little off the wall, but he forwarded me some links to some new papers discussing an alternative to the existing set of ADT drugs. And it boils down to using a transdermal method of delivering it, and it's delivering estradiol. And I guess early results have indicated that it's doing just exactly what all the rest of the drugs do in terms of suppressing testosterone,
Okay.
but it doesn't suppress estrogen in that, which means that, and I think this is the main objective of this particular drug, is to reduce things like hot flashes
Okay.
and some of the other nasty side effects, temporary as they are, of ADT drugs. It's not been involved in any of your studies, so there's no way to really relate whether or not it also would be a drug that might lead us to higher risk of cardiovascular disease. And again, it's brand new. The nice thing about it is very cheap. I mean, we talk about Erlita, which is apalutamide. My friend Michelle can tell you that that's what, about $4,000 a month? Something like that.
And thalidomide is $4,000 a month.
Yeah, that's roughly the amount, but it's I've that and my injections on a 3-month basis mean that I have around $50,000 worth of ADT treatments a year.
But the Quebec government's paying for some of that, right?
Yeah. Pardon me?
The Quebec government's paying for some of that, right?
Yeah, patient programs, our insurance, our private insurance from our employer, so it takes care of most of it.
Yeah.
So I guess related to estrogen, the only thing I'll mention is
Estradiol.
yeah, so it's a form of estrogen. So what I would say is, going back when I was training, so this is many years ago, so 40 odd years ago, let's say, or no, 30 odd years ago, we used to recommend once women reach menopause that they go on estrogen replacement therapy, so a pill. We don't do that anymore. But when this was being recommended, one of the thoughts was, taking estrogen replacement should be given to everyone because it'll help maintain their their ability to prevent getting heart disease. Turned out it wasn't the case. So there was a big nurse study where nurses were taking it and they found that actually led to higher rates of blood clots than taking the estrogen replacement. So we don't recommend it anymore. The only time it's recommended maybe to treat, as you mentioned, hot flash symptoms. Sometimes women will take estrogen creams to help with vaginal dryness, but we don't recommend, estrogen replacement therapy anymore. So I don't know. I would, because of that, I guess I would be a little skeptical. I would also wonder in what you mentioned, what levels of estradiol we're talking about, like how high, they are. I mean, we all actually have estrogen in us, men, but they're low levels, right? So they're not high. Women, they're higher, but, yeah. So the main concern we have in heart patients taking Viagra is if they are potentially at risk for using nitro. So nitroglycerin is a medication. Usually it's given as a spray under the tongue for people with blockages to prevent something called angina. It's not safe to take Viagra with nitroglycerin because it can cause very, very low blood pressure. Okay, so I would caution you, especially if you're have nitroglycerin around and you're using it from time to time, you shouldn't be taking Viagra. If you're not using nitroglycerin, then yes, I can't really think of a reason not to use it. But then you have to be sure you're using it for the right reason. So some people think it helps with libido, like your sex drive. It doesn't help with that. It helps with erection. So if you're having difficulty with erection, it could help with that, but it doesn't do anything for sex drive. It's only to help with erection. But I'd ask, you really should ask your family doctor or your cancer doctor about that.
Okay, ladies and gentlemen, we're gonna stop all the questions. We have to be out of here shortly. Thank you very much, Doctor.